Today we are going to cover a few things. We are going to be looking at design and selected material for flexible dentures. We are also going to look at use of lab composite. This is actually a very, very new material in the country to replace acrylic for 10. You realize that this material can last for even 15 years without changing of color, so long as you cure it well. The same light curing machine. And you can use it to make bridges, as you will see ahead of the discussion. And then the commonly made errors. I've actually now worked with the dentist for 5 years, approximately 5 years. I've observed some errors, which we are going to discuss. Now, when we talk about different design, I think we are looking at mainly partial dentures. Because with the complete, we are not going to deal with the complete too much in the different design. Sorry, why is it? So we are going to look at partial mainly in design, but as we go ahead with the use of different material, we are able to make even complete. So flexible partial dentures, they are dentures you don't need clasp. They don't contain metal. That's why they call them metal-free. And yet they are functional and very aesthetic, as you can see. There are 5 highly versatile properties, meaning we have like 5 different types of materials, and all these 5 have got different design, as we shall see ahead. You find material number 1, if you take it to design number 5, it will not work, as we are going to see which material can work with which design. We are going to see ahead. So, as dentists, let's look at that. You see the patient, and you say, okay, I think this one I can use, I can go with the flexible denture. And lab, do you have this type of material? Because from my experience, the moment you shift one material with another one, the flexible denture will not be the same as you use the material for the specific design. What are the benefits? Because as you talk with your clients, you need to tell them the benefit of flexible denture compared to the traditional one. And one of the benefits is that they are supplied in many, many sets. Are we together? We have what they call translucent, pink, different sets. So it is now the characteristic or the gum of the patient that determines which material is best for this patient. Are we together? So that is one of the advantages. You don't need to, if it's a dark gum, you don't need to say, where can I get the dark color to make the gum dark. With the flexible, they are already there. Number 2 is that, you know, when we are making traditional denture, we do monomer. With the flexible, there's nothing like monomer. And in our science, dental material science, you realize that monomer sometimes react to the patient. So, flexible denture, the moment you order for it, you know there will be no issue of irritation. I mean, irritation can be there, but reaction of the chemical, because it does not, you don't need to mix it with any chemical. All you do is you melt it. There is machine, specific machine for it, which melt it and fire it into the void left by the wax. Because we do wax up after wax up, then we wash it, just like you do flasking of traditional dentures. So for this one, you don't need to mix any chemicals. So this is one of the advantages. Therefore, it's not what allergic to patients. Then the way we design it in a way that it is very difficult for you to actually see that this patient is having a denture, because some of the material are translucent. When the patient wear it, it bond or it bond with the, it is very comfortable. Are we together? With the patient's what? Gum. Therefore, it will be difficult for you to see that the patient is having a denture. And even the class, when we are putting the class, we put it at the margin line. Therefore, the material will be with the gum. Are we together? Not like class where we need to put it on the tooth direct, clinical crown direct. Are we together? Then the flexibility provides a more comfortable and lightweight. Actually, this is what patients like most. Patient wants something very light, something very comfortable, and given the design of flexible denture, you don't need to worry. Actually, on Friday we delivered some denture, actually traditional one. The patient was like, the thing is bulky. So when we changed it to flexible, the patient was very comfortable. So some of you people who are working with the patient direct, you need to recommend some of this for your patient who are complaining of bulkiness. I'm sorry because most of these things you can read them, but we are going to practical bit. But some of this knowledge are very important for you to know to make you give good information to your patient. Now, with the flexing, you require very, very less time. That one, whoever has used flexible denture will actually testify. One thing we do is we block all the undercuts before we make flexible denture. Second thing is we duplicate the model. Okay? Now, the one we have blocked the undercut, we have used to make the flexing. We use it to make the flexing. Then the one for finishing is the one we have not blocked the undercut. So by the time we are bringing you a flexible denture, it is fitting very well, just like the one in the mouth. Therefore, for example, we have this one. You can see how it is sitting. You can. So when we make for you flexi and it's not sitting like that, we get worried that the flexi will not be good, because one, this one is without the blockage of undercut. Therefore, if it's fitting like that, it means in the patient you are not going to look for handpieces to remove the undercut. So it is one of the best things that you are going to take very small time. And also, given the fact that there is small sear side, it means the patient will be very happy. Patient always don't want to waste time. And the moment you are wasting time with the patient feels maybe you don't know what you are doing. So this is the right thing for us to look into. It's the new technology, let's try to use it. And then, of course, as I say, it's flexi. You can heat it with some hot water and adapt it to the patient mouth in case of any changes. Now, there is a problem. One problem with the flexi is that you don't repair it. It means, okay, there is a repair, but the method to repair is very difficult. You get it? We tried for the few times we have used it, we tried it, it was not successful. So what does it mean? You need to avoid doing what they call immediate one. We did it with someone. After some months, the patient was like, there's a space. The patient had to pay. good enough we had explained it to the patient, to the dentist that flexi is not good for immediate. But they said it's okay. So the patient had to pay again to make another one. Then, not all cases are what? Are indicated. For example, if the teeth are weak, are we together? They weaken teeth in other words. So if the teeth are weak, it means they are going actually to weaken them more. Hence, they will come out. Then space. Flexible denture, you need to see that the space between the opposing teeth are at least 5 millimeters and above. Are we together? We had cases where people said as model, when we set the occlusion, they are very, very close to one another. With the flexi, it does not allow that. Number one is that flexi actually require, because there is no chemical bonding. So you need to create what they call mechanical bonding. And the mechanical, we create it on the acrylic teeth. Are we together? So we create holes. So those holes, if now you don't have space, mean the tooth is going to be small. And when it's small, and now you need some space for the holes. So that is where it is contraindicated. Let's look at the material and the design. Now, we have what they call FlexiFast. FlexiFast is actually very good for the first design, that design, the one that cover almost like a normal denture, but you can see the one in the picture here, that one. This is good for, because it has medium flexibility. What most of the dentists did not know is that when we talk about flexible, they expect that the flexibility is so high. Are we together? Or even the patient, when we are telling patients. But with the few experience I have on it, they are not that very, very flexible, but they are flexible. Especially, remember flexibility depends on the length. So you are going to make one like you are seeing. You don't expect the flexibility to be high. Are we together? So you don't need to tell the patient it will be very flexible, and we know that in science, flexibility depends on the amount of length you have. If it is very short, mean you will not get the rightful flexibility you need. So for that, this FlexiFast, we prefer this design. You take this material to that one, it may not work. So you need to, we in the lab, we are able to know this type of design, we need this type of material. So sometimes we tell you we don't have this material, you need to understand it. Another design. Now, with the Flexi Ultra, you realize that some patients, they complain of the what? Bulkiness. Are we together? And yet, you want the teeth, maybe the class of the denture is a bit require the base. So, you may prefer this type of material to give you free space at the palate. Are we together? Yes. So, if you are going to design this with the first material, it will not work. So that's why we said design and the material. Then there is also this design. This design, actually I have one close to that, which we have actually made. So you can see the type of design. At least you are giving patient a little bit of freedom, not to overcrowd bulkiness. There is no way you can achieve this design with the traditional type, the plastic denture we are used to. Are we together? Now, for complete, it's called AcryFast. There's no way you will use the other material we have already looked at to make complete. We tried them, but we have failed. So you have to be careful. Actually, when you know some of these type of material, you are able to actually to understand whether somebody has changed it or not. Then there's also that design for complete. Lastly, we are on the type that can help us make framework. If you don't want to overfight with the metal, trimming metal, you can use what they call flexi-acetate. It also helps. All the design are the same. You do blockage of undercut, and then you go and flask, and the rest of the procedure are the same. Then you fire flexi-acetate. So that is also another design. And then also we have what they call biostrong. This one actually you can use it to come up with the when you have, for example, implant, you can use it to come up with a crown, joint one, like one is there. You can come up with that. So, let's move to the next material, which is called Nesco paste. Any question? How are we going to move? We move then question? Oh.
I think if you are in doubt, you can interrupt.
Because we are moving to the next material, which is lab composite. We move on? Yeah, being quiet means you're understanding. Eh? So, this is another new material. Actually, in Uganda, I think it's only my lab trying to do a lot of it. Because when those people came from Nairobi, Ivocla, they trained us, and I saw it very important that we need to introduce it also in Uganda to help us. Lab composite actually is very, very nice. The look of the teeth, the bridges, they are very good. When you cure it, very well. So, the appearance and the clinical behavior is very good. You find that when you are trimming it, you can even feel how good it is. So, that is what they are saying. It actually absorbs what? Forces compared to porcelain. For sure, it's very good. The day you will use one, I can assure you, you may not go for PFM because they are good and strong. Of course, as we move on, the preparation requirements are supposed to be followed. It requires around 0.6 to 1.5. So, why do we need it? It has very good set stability because they are made actually in different sets, A1, 2, 3, 4. Just like the composite you have been using. It's the same type. You cure it in the same way, but take more time. Okay? So you don't need to fear. Layer thickness tolerance. Even though you're using metal supported, when you put the opaque, you don't need a lot of it to cover it. So that is what they are meaning by layer tolerant. Then flexible, so is of equipment. You only need light curing machine, which you have it in your dental chairs. Are we together? And the material. You don't need a casting machine, okay? And you can see the look. These are the look. Framework free, you can do inlay, onlay, veneers, and anterior teeth. But we have been doing it also on posterior for those who give us good space. Good deduction, occlusal deduction. You can also use it on what? but it's only for crowns when we are looking at it framework free. Then when we go to framework base, you can do even bridges. We made a few days ago 5-unit bridges. And the bridge was looking so nice because the space was okay. But of course this one requires you to follow all the PFM procedure until stage of layering porcelain. That's when now you do compo. Are we together? Then, you can also use it for denture. One thing you need to know about compo is that, for example, if you are delivering PFM or zirconia crown and bridges or IMAX, when you have what they call margin space, all you do is you apply it. It can help you to seal. What you do is it has a material called link, a liquid called link. This liquid, you roughen the area you are going to use, then you apply that link, just a smear, what you call etching. You apply there, light cure it, then apply the material. You can see they're just like normal compo. So when you apply it there, then you light cure it and polish. So it can also help in that. Then we have, you have a bridge with the pontic maybe hanging. You can also, you don't need to go to the lab for such filling. You can use the same. Then there is a crack on your denture teeth. Some patients come, the denture crack, or you need to remove, it has broken. The incisor edge maybe is broken. All you need is the connector. This one you apply different liquid. It's called connector. This connector you apply it just like the etching. Then you apply your compo. You build it. Because this compo has got A1, A2, and then incisor. Incisor is mainly for incisor purposes. So you only need this. Now, for denture, we are trying to say if I want to characterize the patient's denture, maybe the patient had stain. So you want to have that look like denture. This is what we do. Now, that is also the end of NESCO. Are we together?
In the beginning,
So let's now go to what we do most. That is PFM. I mean, abutment preparation for crowns. And this presentation, I'm making it from the experience I've gotten with dentists. Any question, though? So, when we are preparing our teeth, we look at we do them mainly for 4 important things. You do them for all metal, ceramic, and composite. The material, the preparation ideally depends on the material you want to use. Are we together? And therefore need to reflect on different material you are going to use. Preparation for all metal might not be the same for metal ceramic, might not be the same for all compo. So you need to understand which type of crown or bridges you are going to make. So, when we are doing our crown prep, I know this one you have covered it, so I just want to recap as we move to where lab needs you to do most. Preservation of the structure of the tooth, retention and resistance, structural durability, and then marginal integrity. Lastly, you need also preserve that. My interest in this discussion will be number 4, number 3. Actually, ideally they are all important, but for me, my interest is number 2, 3, and 4 as lab. Okay. When we look at it, how do we preserve what? A tooth structure. I'm looking at the most common preparation I've been receiving, which is supra and what? And sub. These are the most common one. And why? We want to avoid weakening of the tooth. Are we together? When we are going to preserve the tooth structure, we are avoiding it so that we don't remove a lot. We are trying to not to compromise pulp. And then we are looking at, is it a partial veneer or full? Something like that. Then how do you do that? Then we need to remove only what is necessary. Yes. And we use less destructive alternative as we look at the path of insertion in the retention and resistance. We are going to be looking at taper of when you are doing your preparation and the length. These are 3 things I looked at when we are going to look at retention and resistance. So, this thing is not giving me what I want very well, but I think we are moving on. Now, as dentists, let us understand preparation very well. According to the theory, when you make your preparation parallel, we tend to achieve greater retention. Now, somebody did this research and got this graph. This one is retention. Remember, when we are making our abutment preparation, we look at the retention in our mind. Now look at the taper. The taper, what we call taper. Now, I've been receiving preparation like this one so many times. Now, are you seeing the way, how much the retention is? It's around 20. Are we together? So, when we are going to do our preparation, let us put this factor very, very important. It's not about cutting. It is about getting the best for the patient. You are destroying the patient's tooth up to this level. At the end of the day, retention is very, very poor at 20. But look at this person who made it parallel. Are we together? He's having a better retention. I don't know whether you have understood the graph. Thank you.
But also, we are told not to make parallel preparations.
I'm coming to that area. I'm coming to that area. You talk.
It's supposed to be a paper so the preparation.
Yes, that is. That's why the heading is. So as you make it, let it be what? But we are going to the best way we should do it and what lab prefers.
Maybe as you go,
Uh-huh.
is 100% parallel, there is maximum retention.
They talk of 16 for anterior and 22 for posterior. But that one you can read. Me, I'm looking at the error in the lab. What I prefer in the lab. But they talk of 16 for anterior and 22 for posterior. We are going to go where this one was just like recaps what I wanted you to know when you're going to make your preparation, what lab would love to see. The next thing is occlusal reduction. We are going to see it in the next one, functional cast bevel. They are very, very important. These three, then axo reduction. There are many, but these three, we like seeing them in the lab. When they're there, we prefer them. When you have good clearance of the occlusion, we have good clearance of the functional cast bevel and axo reduction. Now, when we are looking at occlusal clearance, I can assure you I've been facing challenges. Number one, look at the first one. The deduction is very minimal. And now, remember you want me to produce for you very good what? Crowns. Now, the amount of material here is going to be minimal. And the moment it's minimal, it's very weak. It has a very weak bonding with the metal. Therefore, in short time, the patient will come to you and say the porcelain has chipped off. Because I have been given a very small space to apply my porcelain. Now, what doc you are talking of is this. We prefer this, the bevel and the functional cusp. And then you see how taper it is. So you will realize that most dentists are giving me this one. Most of them just drrr, drrr. Okay? They are not following. So let us understand why we need it to be the right way. You can see how that one is looking like. And you know, when it is not properly followed, the danger. At the end of the day, you want a crown which is nice looking, and then it has good bonding. Now, we talk of retention at some point, but they are saying the moment you make the occlusal flat, you are making the preparation shorter. Therefore, the retention will be poor. Then what happened when the occlusal, inadequate occlusal deduction? We are saying the restoration will be weaker. And then this one actually happened to this number, whatever. It happens so many times. You are trying to reduce on the metal or porcelain, you end up perforating the crown or the bridge. So, and it is because of poor deduction of occlusion surfaces. What happened if the cusp, what they are meaning by cusp bevel, they are meaning you are not making it well. What happened? I look at only two. That area is going to be thin. Remember, it's the area where it's actually a functional cusp. And in that area, there is tight bite. So, for me, when I'm making you a crown, we prefer fighting occlusion. At least leaving it by some millimeter of the occlusion. Now, if the area which are important for the bite is not well reduced, then the eroded person want to come. I think he's around. You have his name? So, perforation will always occur if there is no good occlusion deduction. Axo is another common errors we get. You do preparation and then you leave very minimal space. I think sometimes we fear to, because it is between, we fear that we are going to touch on another one. So we end up doing a very small deduction on the side. And yet when you do small deduction, the errors start from wax up. When we are trying to wax us abutment, they don't actually come easily because the space is very small, and you know wax is actually very weak. It is not strong. So by the time you are pulling the wax, we have some spaces. It does not go deeper up to the margin. So you find that errors start from there. That's why we end up getting what they call periodontal problem. Right, even from metal, even though you try to put porcelain, it will still give you space. Because we don't have enough space that can, the material that can withstand the force between the what? Between the teeth. That's why there are always some small spaces there. And that is very dangerous. Then we look at margin. In the lab, actually, our preference is that we need margin which are well defined. At least, if you want your preparation, with your PFM, zirconia, and all type of crown and bridge to be okay, the first thing before you take impression is to confirm that the margins are well defined. This one we have suffered with it. I think from today I expect people who are here are going to take maximum care of that. Before you take any impression, make sure the margins are well defined. Are we together? Because if they are not well defined, we are going to assume in the lab. We are going to assume. It is very common to the palatal and lingual side of every abutment. People, I think, when we are trying to prepare, that is the most difficult area maybe to do. Because most of the preparation, the lingual and palatal side, are always having a minimal defined margin. What could be the problem? So, you need to discuss that. But from today, those who are here, please, let us, when we are doing preparation, let us make sure the margins are well defined, because it's the most common errors I've ever seen in bonded restoration. And you know, one of the things you need to know is that when you give this crown, when you cement it, the patient needs to do some cleansing. Now, if the margins are not okay, that will be the area that will attract what? Food particle. Hence, there will be periodontal what? Issues. You know that better. So, let us try to make sure they are defined. And even some margins, they are supposed to be smoothened for easy impression taking. There are margins whereby, when you are taking impression, even the impression material cannot capture it. Are we together? So you need it well defined. You need, if possible, to expose it so that you get better impression. So margin is very important. Occlusal clearance is very important. And then axial proximal clearance. You need to, those three are very, very important. Of course, we talk about bevel and taper. These are very important things in bonded restoration and abutment preparation. You need to take care of that. Then I think the rest, now we go to the final margin placement. It can be, that is a margin placement. We have Margin there. So let's look at now the practical discussion here. Now, for the 5 years I've done bonded or fixed, I've discovered some people, before they sit on the patient to start preparation, they don't plan the final outcome. For you to be a good dentist, and for you to tell lab that you are good, sometimes some of these errors start from where? From the clinic. But you know, for us, we are compromised. You want business. Are we together? So a dentist actually send you work, you are really saying this abutment is not good. But because you don't want to lose the job, the client, even when you call client tell you, please, just go on with it. When you do it, the work fail. You are the one on the wrong. Are we together? Now, that brings me to point number 1. Let us predict the final product. Are we together? Before you sit on the patient to start your preparation, you tell the patient what the outcome is. If you know this work is going to have what they call metal show, tell the patient, you know the work is not going to be the best. It's good you predict it, such that you are able, when the work comes, you are not again saying, now you see the lab, because now when you're with the patient, you have to blame what? The lab. And for us, we are compromised because we want business from you people. So, let us predict the final product. Number 2, correction of malalignment. This one is another problem. We want to make a crown to correct malalignment. Are we together? Now, to make it worse, somebody actually is trimming more on the side which you don't need actually to trim. And then the side you need to trim more is actually left. Are we together? Either you trim it, you think now it's okay, but when it comes to the model, it is not okay. It is still actually malaligned. And that calls us to point number 1. Why I brought point number 1? Most of these will be going back. You have not planned actually. You want to correct malalignment, so make sure the area which is out of alignment is more trimmed, isn't it? I can tell you, I'm repeating a work for that. The work was malaligned. Now, the abutment came to us, it is actually out. What happened to the lab? You are doing PFM. You need metal, at least minimum 0.3, and you need porcelain, at least 1.5 or 1, isn't it? So, will you correct the malalignment? No. So from today, let us plan for the final product. Are we together? Now, I've worked with dentists who are doing this. Very few. Number 3, very few. Those I'm working with it. I think extraction instead of post-crown and bridges. I have this model. You can also pass it. I think most people will prefer extracting whatever we call it what? 1, 2. No, not 1, 2, but the part remaining. The root. Are we together? But actually, I think only last one we have done over 10 of that with one of the dentists. I think, to me, we need to try it. Let us not say, let's extract and we give you denture and then we put our PFM or zirconia at later stage. Let us try that. I think that will help many dentists, patients. Because at the end of the day, it's saving money for patients. What we do there, I think you go through X-ray, then you create, you do root canal, then you create that. So we always do that post-crown. Then after, this dentist prefers zirconia or image. So after we send it back, you cement it, take another impression, then we make zirconia or image. But we can still do PFM on it. I think it's a good thing to introduce in Uganda. Or to make it part of you as a dentist. Isn't it? Making post-crown. Try to build hard for that. Another thing is this one. I didn't know impression taking is still a problem to many dentists. It's a very difficult thing to some people, but very easy for others. So, error for all the processing, whether denture, bridges, if impression taking is not okay, then you are going to fight with lab person. All we do is we cast and fabricate. The crown is not fitting. The denture is not fitting. Where is the problem? We sometimes don't know actually it is impression taking. What do we do? From the few years, I think all you need to do is to make the patient relax. Make sure all the lips are relaxed. And some patients actually want to, because they fear this is the new material to them. So you first need to reassure this patient, and then when they are trying to cover their eye, please tell them to open and sit when they are relaxed, such that the lips are relaxed. Are we together? Actually, you know, some of you pass through dental school, you find the whole packet of alginate is done. You know it. Yeah, Dr. Karan? So, you know what it means. But the trick is, let the patient relax. If the patient is trying to make the soft tissue, the lips hard, tell the patient cool. And then when you put the tray, make sure you are able to open the lips, both down and up. We have returned so many impressions, our own model to dentists to repeat. First of all, the patient has already traveled back. The model is very bad. Then we tell you, please, we need another model. So you can see the cost and the time. But the whole idea is making the patient's lips soft, relaxed, not to close the eye, because eye, I think, is related to soft tissue, lips. So when they are closing it, the lips is hardened a bit, and that means the material is not going to flow. Are we together? Because the trick is material flowing. But we prefer, of course, for bonded restoration of crown bridges, we prefer silicone. Are we together? Now, at the same time, when we are looking at this, let's look at the stone we are using. These are something, I'm discussing what I pass through every day. The stone we are using also determines the type of work you are going to get. If your stone you are sending me and a model with a very weak stone, and you're going to tell me, make for me a crown. Remember, if it's PFM, I have to undergo so many stages. Wax up, metal finishing. So every time I'm doing that, remember I'm checking it on the model. And the stone is very weak. Are we together? Meaning, I'm going to be rubbing the abutment. Now, when I'm making the final crown, it is not now on the same abutment you have sent to me, isn't it? Therefore, when now you are with your patient, you try it, it will not sit. What happened? The crown is bad. So let's work together, try to use the right material. We prefer a high strength material stone. So if you cast work from your place, you don't send it to the lab, then make sure you stock high strength stone for bonded or PFM, crown and bridges. Then ordinary stone for dentures. It's good also for you to have those if you want to be casting your work before. Then lack of teamwork. Teamwork, there are few dentists here who at least we discussed before. Anything, they call me. So many times I've been called to see the type of the abutment, to see the preparation, to see the occlusion. It is called teamwork. You have your lab, you need to engage. It makes me understand you, such that whenever there's an error, we own it both, other than blaming one side. Are we together? So let us actually try to engage our lab people. Let us engage them. They are very, very important.
What information will you expect from a dentist when they're sending you work?
What information? Now, actually prescription. When we talk about prescription, I mean you have to tell me the state of the patient. You have to tell me the bite of the patient. Actually, if you can't take the bite, I wrote bite registration. We are going to look at that. You have to tell me about, of course, the time of delivery. We don't want a situation, it has reached the time where your patient is in your dental unit, the lab actually is not aware that the work is for today. Are we together? Those are the communication. But are you aware that is why many of you run away from one lab to another? Because somebody is not keeping your time. So you say, now look at the patient is on you, and now you're on the technician. So communicate, write it. I want the work on Friday at this time. The set is this. Are we together? They are small things, but they affect the relationship between lab person and the surgeons or dentists. Are we together? So, but calling lab person to your setting when you're planning abutment preparation is very, very important. We are always on the move. Today you are called to go there and you come back, you are sitting again. But because you want to discuss patient. And at the end, those who have called us, I think we have worked with them very well. Because you understand you are clinician. Size of the abutment as compared to the existing teeth. This is another common thing. And it takes us back to what? Number one. Planning your final product. Tell me something. If I have these two premolars, then I do like 1 millimeter deduction, and you ask me to make for you PFM. Will I make this PFM the same size with this? It can never be. It can never be. So it means if your deduction is minimum and you're telling me make PFM, because even CAD/CAM will not accept if your deduction is not enough. The computer will show you that it is a minimum thickness. Therefore, when you mill it, it is going to have holes. Are we together? So even in PFM, masters, as I said, we are compromised. We fear to return the work. But at the end, the quality is going to be low. One, the size of the crown is going to be bigger than the existing teeth. Okay? Meaning, and that is because you have given me abutment which had minimal deduction. It takes us back to prediction of the final product. Are we together? So, from today, let's go. Actually, tomorrow, if you have a patient for PFM or you try to be thinking about this. If you have your lab person, call him. Start planning with him or her. Then start writing the delivery time. They said, because so many time work recess, there is no shade, you have to think the abutment is not okay. It's a common thing, this point. Very, very common. So, if you want me to give you quality crown, then make the rightful deduction. That will make me make metal, make porcelain, and I get the same size. By the way, for your information, there is no lab person who would love to make a crown bigger than the existing teeth. Are we together? So we had somehow, with a small error in the procedure, we get to that. I already, occlusal study. Here I'm meaning, before you do any deduction or preparation, try to study the bite of the patient. Now look at the point. You have class, let's say class 3. Are we together? With maybe 4 teeth. Now the last tooth is actually the one which was in occlusion. Are we together? You have done abutment preparation on that tooth. Meaning, I don't have, as a lab, even the patient will lose the bite. Are we together? Now, when you send that work to me, to the lab, without indicating the bite registration, the bite of the patient, it means the lab is going to do what? Predict. And you know what it means by prediction? You are either right or wrong. Unfortunately, the blame goes back to what? To the lab. You gave me work which is high, but ideally lab people also don't want to give you work which is high. But because they have assumed wrong bite. Therefore, when we are, especially when we are casting our work from our clinic, let us mark the bite. Okay? Or let us take the bite. I can assure you, when you send your work to the lab with good preparation, occlusion is okay, you will not suffer delivering your what? Your crown or bridges. Because there is no lab person who wants to make things high. So let us look at that. And that is studying what? Occlusion. Study your occlusion and make sure your deduction, your preparation have got enough clearances. Especially if you don't want metal show. Because as I say, you plan your final product. If your final product requires that you need metal show, then let it make deduction which require metal show. If you don't want metal show, make good clearance. Are we together? I think these were the errors so far I saw in the field, and I hope from today we shall try to correct them. So these are just preparation. You can see the margins are clear, and when your margins are clear like this one, I can assure you lab will not fail to give you good crown with good fitting. Are we together? And at the end of the day, the patient is going to go when everything is sealed. Thank you for listening.